Thank you. I would like to thank again Professor Hosni for the kind invitation. I'm not Professor Riambau. I'm acting on behalf. I try to do my best. Thank you, Hermano, for the opportunity to be here today. So this is the index of the presentation and the scope of the problem when we are speaking about the type B dissection, the acute type B dissection, is that if we look at the literature, almost 50% of the initial type B dissection are so far complicated, and even from those initial results, even more get complicated in the very beginning. And if we follow up the patients, we know that most of them will have a crossover, and finally more than 50% of the previous uncomplicated will become complicated. So this is a very big problem. And when we follow the indications for intervention and we look at the current literature, we look at the guidelines, we have an overview. We know that the aims of treating type B dissection is maintain or restore the perfusion in the complicated situation and prevent complications for the future. But it's very difficult to look at them and see how are they going to become complicated. So when we look at the indication for intervention, it's clear for the complicated type B dissection, rupture, back pain, refractory hypertension, malperfusion, and retrograde, of course, retrograde dissection. But what about the uncomplicated dissections that will become complicated? This is what Vincent normally calls type B dissection at risk. And this is a different concept because we know and we have quite a good level of evidence on how to treat these patients with endovascular repair in the acute setting. But to prevent this kind of complications, we are beginning to have some evidence that this is reported on the guidelines on how to do it. These are the indication for intervention for this kind of complicated type B dissection that we know, and we know that this situation is complex, it's difficult, it's very bad for the patient with a high mortality and odds ratio that is independent from any other factors of risk. This is a picture from the 2002 case in the clinic hospital where they performed this restitution of the malperfusion using a thoracic graft, restoring immediately in the post-op the flow to the limbs. And how can we do that? We have been through a very nice talk of Germano in the very beginning, speaking about the stabilized, so I'm not going to speak again of the petticoat. You all know about the petticoat and the upgraded technique of petticoat, that is the current stabilized technique that is really elegant to restore the flow and go for that. But what about the uncomplicated at risk? This is a difficult concept to define, but how to treat this? Because we know there are some unpredictable factors for this, and the partial lumen thrombosis has been set up before. Also, the false lumen diameter in the very beginning, the larger, the worse. And the location and size of the entry tier has been really good defined by Evangelista all since some years ago. But it's not only the position, it's also the shape of the dissection, a spiral versus non-spiral, much worse spiral than non-spiral, and the location of the entry tier in terms of inner curve and shorter distance to the LSA. Again, there are more recent techniques dealing with flow dynamics, trying to predict how the dissection will behave in terms of flow dynamic. A high flow with good entry and good out is much favorable than a low flow that is sometimes or many times related to false lumen partial thrombosis. Again, it's not only about flow. The flow is produced by the size of the entry tier and the location. When you have a good average or similar diameter of the proximal and distal entry tier, looks that the evolution is going to be better. Do we have some biomarkers to identify this kind of uncomplicated dissection at risk? Yes, we have some works done on biomarkers and the dimer, and also the PET scan can give us an overview of the inflammatory response of the whole aorta. The bigger is the inflammatory response, the worse is going to be the evolution. So if we summarize all these factors that we went through, there are these nine factors, anatomical and biomarkers, that can produce some kind of definition on what is an uncomplicated type B dissection, acute type B dissection at risk of become complicated. And so in this kind of situations, when do we need to treat this patient? This is most clear that the subacute phase is probably the best situation, the best time to treat the patient in the subacute phase. The results and the freedom from mortality and reintervention are much better. But take care of this because this comes at a cost. There are stroke ratio reported up to 10% with some more or a few more complications treating these kind of patients. So summarizing the concept, when we face an acute type B dissection, it is complicated, we go clearly to endovascular repair. If it fails, we can go to open repair. But if it is uncomplicated, a close image surveillance is mandatory. And if we identify those factors that can label the dissection type B at risk, then if they are not, we go to surveillance. If we identify, we cross to the endovascular stage and repair, or if any complications appear in the meantime. Finally, as final words, the complicated type B dissection acute should be intervened by endovascular means in the emergency setting. More than 50% of uncomplicated type B dissection will become complicated in time. The key is to identify these patients with some morphological and even some flow dynamics or even some biomarkers and treat these patients in the subacute phase. But these procedures can produce some complications themselves, so be careful with them. Thank you very much.